Hello, in this fourth and final talk on the issue of radiation burns in interventional radiology, I want to present an outline what I think is a sensible policy for use and to be adopted by the practitioners in this particular field. As I've indicated, we have a number that is shown to the operator called the interventional a reference point air kerma measured in grey. You're given this number, and I explained what this number was and how it should be used in my first talk, and there's a fairly good correlation between that and the peak skin dose, and it's the peak skin dose that actually predicts the likelihood of you getting a radiation burn. So what is my recommendation? I would say, look, you have a number, the air kerma at the interventional reference point. For all practical purposes, as you're doing the procedure, my advice is you assume that this is the peak skin dose. It's a good assumption because, as you saw in the second lecture, it usually is a conservative number. The true peak skin dose for most patients, most of the time, is less than this. And I say this because there is no practical, realistic alternative to making this assumption in day-to-day clinical practice. So don't worry about it. I will give you some guidance later on when the numbers get to be quite high. If your number is below 2 gray, my recommendation is absolutely no action. The chance of a radiation burn is incredibly small, so keep calm and take no action. If you exceed 2 gray, I think it would be prudent to warn the patient, tell them what might happen, tell them where it might happen. And so you point out where the radiation beam enters the patient, you give them an idea of the size of the beam, and you tell them that if a radiation effect is going to happen, it might happen in 10 days. And if it does happen, as doctors, I think you should be giving them a recommendation as to what they ought to do. Now, if your number exceeds 5 gray, then I would recommend that you consult with a medical physicist. The medical physicist will look at issues of any beam overlap. If you have multiple beams, the physicist will take into account attenuation of a table. You might be losing 30% of your radiation, and the medical physicist will consider things like where they believe the IRP to be located relative to the patient entrance skin dose. The other thing that the medical physicist would do, is certainly what I would do, is I would take a detailed look at the kind of procedure that was being performed. I would want to know where the exam was being performed in terms of the anatomical regions, the projections, the characteristics of the patients, and how the procedure was done. So I would actually sit down with the IR operator and make sure that I understood what was taking place. So I'm warning you that if you consult with a physicist, you should be in a position to explain what you did in the IR procedure. I personally would also say that if the number has exceeded 5 gray, 10 days or so, you have a nurse that would contact the patient just to confirm that there are no adverse effects, and if there are adverse effects, then the nurse can advise as to what action the patient should actually take. One issue that sometimes does come up, and that is the issue, what if you're doing an IR procedure and the patient has already had an IR procedure? What is the recommendation? And the recommendation that I would give is you have to probably consult with a radiobiologist, but if you've done a procedure yesterday, I would add yesterday's dose to today's dose, so I would add the 2 doses. The procedure was done a week ago, I personally would add last week's skin dose to this week's skin dose. If it was done a year ago, I would ignore the prior exposure and assumed that the skin had recovered, and in between those two extremes, then I would progressively discount any prior radiation dose, but I would do that in consultation with a renowned radiobiologist. I personally would contact Eric Hall and see what advice he could give me. So if you're interested in the issue of managing the radiation dose in interventional radiology, Don Miller and his colleagues have published a paper in Radiology called The Clinical Radiation Management for Fluoroscopy Guided IR, and it's full of very useful tips that will help you to look after your patients and make sure that you're delivering the optimum care, maximizing the diagnostic performance of your procedures while minimizing the possibility of any adverse effects. So that's my final presentation, and again, if you have questions, feel free to drop me an email at walterhuda@hotmail.com. It is the best way to reach me. Thank you.